This talk is about seizures and epilepsy. Here are the class objectives. You do not need to read them. We will use them to chart our talk. The talk will be conducted using conversational and question and answer formats. The first question is, the differential diagnosis of seizures include A. Vasovagal syncope, B. Psychogenic non-epileptic seizures, C. Cardiogenic syncope, D. All of the above. Seizures should always be suspected in the presence of a paroxysmal clinical event, but so should other conditions. The suspected conditions should be confirmed or excluded based on the nature of the event as determined by history and physical examination. At times, the information gathered from the history and physical exam suffices to reveal the nature of the event, and we can readily establish the diagnosis of vasovagal syncope, cardiogenic syncope, psychogenic non-epileptic seizures, or seizures. These are the most common causes of paroxysmal clinical events. But in other occasions, the nature of the event is not clear. In such situations, we should consider cardiac pathology first and then brain pathology. The reason that a brain origin of an event should be considered second in questionable cases is twofold. First, with heart pathology, there's often no second chances. Patients die. Whereas with brain pathology, usually there are second chances. The second reason is that heart pathology may hurt the brain, whereas brain pathology seldom hurts the heart. So the answer to this question is D. Next question. A clinical paroxysmal event that occurs during exercise is likely to be A. Vasovagal syncope, B. Psychogenic non-epileptic seizure, C. Cardiogenic syncope, D. Seizure. Factors that should make us consider vasovagal syncope are listed in this frame. Take a few seconds to read them over. I will not enumerate them one by one. What I will say is that in their absence, that is, in the absence of a credible trigger, the possibility of a vasovagal syncope is very remote, and that the link between syncope and trigger can be easily established in many cases. I will give you two examples. The first example is postural vasovagal syncope. Postural vasovagal syncope occurs as patients stand up, and they can be reproduced in the office by a tilt test, as you can see in this frame. Notice that following the tilt, after a brief period, here labeled pre-syncopal phase, blood pressure drops and so does the heart rate. The second example is vasovagal syncope triggered by hyperventilation. Vasovagal syncope due to hyperventilation, a relatively uncommon condition, can be easily diagnosed since the syncopal episode can be easily reproduced by having the patient hyperventilate while monitoring blood pressure and heart rate. Now, let's talk about the heart, the organ that usually does not give you second chances. Factors that may lead to the clinical suspicion of a cardiogenic syncope are the occurrence of syncope while exercising, the absence of a trigger as those encountered in vasovagal syncope, a history of cardiac disease, a family history of sudden unexplained death, and additional cardiac symptoms. I will give you an example of the latter. This EEG epoch was recorded in a patient suspected of having seizures that complain of palpitations. Take a few seconds to look at this epoch. What do you see wrong? If you have not looked at the heart tracing, do so. As you can see, the heart stopped during the procedure. Psychogenic non-epileptic seizures are also in the differential diagnosis of clinical paroxysmal event. It is important to remember that 10 to 15% of patients with epilepsy have psychogenic non-epileptic seizures. Hence, the presence of psychogenic non-epileptic seizures does not exclude the diagnosis of epilepsy. Factors that may lead to the diagnosis of pseudo-psychogenic non-epileptic seizures are falling down and remaining still for over 2 minutes, having all the attacks while at the doctor's office, having many attacks and no morbidity, having many different type of movements instead of a repetition of the same movements during the episode. Please look at this video so you can get an idea of the type of movements that occur during psychogenic non-epileptic seizures. Other characteristics of pseudo-seizures are side-to-side movements of the head, emotional outbursts with attacks, situational responses. I recall a patient that had a pseudo-seizure in my office, and during the jerking, he knocked down some of my books. He then stopped convulsing and said, "I am sorry, doctor," and then went on with the jerking. Pseudo-seizures can also manifest as episodes of eye closure. Now, let's talk about epileptic seizures. The factors that may lead us to conclude that a clinical event is an epileptic seizure are an stereotypic aura, focal motor or sensory phenomena such as arm jerking and tingling sensation around the mouth. Another characteristic of epileptic seizures is fast progression of symptoms. Patients with seizures do not break the fall produced by the event. Seizures are usually associated to increased muscle tone. Cerebral hypoperfusion, as it occurs with syncope, usually produces flaccid unresponsiveness. Postictal confusion is the rule in most patients with seizures. Biting of the lateral aspect of the tongue, especially if only one side is bitten, is very characteristic of epileptic seizures. So the answer to this question is C. Next question. A 10-year-old girl that awakens from night sleep with twitching of the right corner of the mouth and then goes on to develop right arm jerking but retains awareness is likely to be having A. a simple partial seizure, B. a complex partial seizure, C. an absent seizure, D. a generalized myoclonic seizure. When presented with such a history that clearly reveals the nature of the event as being a seizure, the first step is to define the seizure type. Seizures are classified by types as partial seizures, also called focal seizures, and generalized seizures. Partial seizures are further divided into simple if during the event the patient retains awareness, or complex seizures if awareness is lost. The other major type is generalized seizures. Generalized seizures, to which we refer as primary generalized seizures, involve both hemispheres simultaneously. Primary generalized seizures can be divided in 5 groups. The most common one is tonic-clonic seizures. As the name implies, a generalized tonic-clonic seizures is characterized by tonic contractions followed by repetitive jerking. The second type of generalized seizure is tonic seizure. The third type is a tonic seizure. Here the patient just dropped. Consciousness may or may not be lost during the episode. The fourth type of primary generalized seizure is myoclonic seizures, and the fifth type, absent seizure. A partial seizure, as indicated by the long arrow just introduced, can generalize. This phenomenon is called secondary generalization. Secondary generalization may manifest as tonic-clonic seizures, drop attacks, and rarely as myoclonic activity. Secondary generalization does not present as absent seizure. Partial simple seizures can become partial complex seizures. So the answer to this question is A. Next question. A 10-year-old girl that awakens from night sleep with twitching of the right corner of the mouth and then goes on to develop right arm jerking but retains awareness is likely to be having A. a prefrontal seizure, B. a sensotemporal seizure, C. a mesiotemporal seizure, D. an occipital seizure. So our patient seizure type is simple partial. Now, to answer the latest question, we would like to know where is the seizure coming from. That is, where is the epileptic focus? Seizures have a timeline. They can start with an aura, next automatism, next the ictal period, and then the posictal period. Some seizures go through all of these stages. Some have no aura. Some have no aura nor automatism. In this later group, the ictal and posictal periods constitute the complete event. Posictal periods usually do not provide localizing clues, but as we will soon see, sometimes they do. Now, I will start defining the terms just introduced, starting with aura. An aura is the initial non-somatic motor manifestation of a focal seizure. Awareness is not lost during the aura. This is an epoch of EEG. The arrow are pointing to the channels displaying the most prominent electrical seizure activity. The onset of the seizure, the electrical focus, is in the right temporal region. The blue thick line I have just added indicates the onset and duration of an aura that occurred during this tracing. It consisted of the patient hearing sounds. An aura can be classified as simple or complex. Simple sensory auras consist of noises and voices when the transverse temporal gyrus of hurt or area 41 is involved. Tingling, numbness, or pain when the postrolanthic gyrus is affected. Bad or metallic smell when the frontoorbital region is involved in either side. A rising epigastric sensation when the mesial temporal lobe is affected, or flashing lights when the pericalcarine area is involved. In addition to sensorial simple auras corresponding to seizures initiating at the different primary cortices, we can have simple auras manifested by autonomic manifestations. Piloerection occurs with insular and orbitofrontal involvement. Piloerection consists of hair moving up and down, as you can see in this flick. Palpitation also occurs with insular and orbitofrontal involvements. Other autonomic findings, such as changes in skin color, blood pressure, and pupillary size, have been reported as autonomic auras. Auras can also be complex. Complex aura result from unimodal or multimodal association cortical area involvement. Complex aura can be classified in 5 types. The first type consists of dysphasic symptoms. This type of aura is characterized by utterance of out-of-context words or repetition of the same words over and over. This type of aura usually indicate seizure arising from the non-dominant hemisphere. The second type of complex aura consists of dysnestic symptoms such as flashback, jamais vu, or déjà vu. Déjà vu is by far the most common symptom in this group. Déjà vu is characterized by a sensation that what is happening has happened before. These nestic auras occur with involvement of several cerebral regions. Most often they occur with mesial temporal involvement, but they can also occur in patients with inferior frontal lobe involvement and lateral temporal involvement. The third type of complex aura is called affective. They consist of the full gamut of emotion, including depression, anger, elation, and fear. Affective apnea are most frequently seen with lesions in the mesiotemporal lobe or lateral surface of the temporal lobe. The fourth type of complex aura is very peculiar. This type of complex aura consists of distorted illusions, that is, distortion of size such as macropsia and micropsia, distortion in shape, weight, distance, or sound. These types of complex auras are usually a manifestation of temporo-occipital, parieto-occipital, and temporoparietal epileptic foci. One peculiar illusion aura consists of body size distortion called Alice in Wonderland, named after Lewis Carroll's book of the same title. The fifth type of aura is hallucination. Hallucination implies not a distortion of reality, as illusion does, but the creation of realities that do not exist. An example of hallucination is smelling odors that are not there. Hallucinations are seen in patients with temporal lobe, amygdala, and hippocampal pathology. Next in the timeline event of a seizure, we find automatism. I show you this EEG epoch of a right temporal lobe seizure with auditory aura before. I am bringing it back to indicate that after the aura, the patient went on to have automatism, characterized by confusion and lip smacking. Automatism are defined as involuntary motor actions and impaired of awareness occurring during or in the aftermath of epileptic seizures. The patient is usually totally amnesic for the event. Automatism are the consequence of focal seizures involving the motor pathways. Automatism occurred with frontal and temporal focal seizures. The most frequent type of automatism are called oroalimentary automatisms. They consist of masticatory, salivation, and speech arrest. They occur with frontal opercular lesions and also with amygdalar involvement. Another type of automatism are gestural automatism. This type of automatism usually consists of finger gesturing, buttoning and unbuttoning the shirt, but probably the most peculiar of gestural automatism is a type of gestural automatism called gelastic seizure. Gelastic seizure consists of laughter without joy. Gelastic seizures are seen in patients with hypothalamic hamartomas, as indicated by the asterisks in these 4 MRI views. The seizure pattern arises from the frontal lobe in patients with gelastic seizure. Other types of automatism are verbal automatism. The distinction between this dysphasic aura and verbal automatism becomes blurred since clinical manifestations are similar and the labeling of an event one way or the other is in clinical settings capricious. And the last type of automatism I will mention to you is ambulatory automatism. Ambulatory automatism consists of circular walking or running. This type of automatism may occur with temporal or frontal lobe seizures. From automatism in the time progression of seizures, we go to the ictal period. The ictal period is the time span where the manifestation of the seizure becomes established. As you can gather, the term ictal period, automatism, and oral all imply time progression and territorial expansion of the same event, the event being an epileptic seizure. The ictal period can be occupied by generalized seizure and not help with localization, or it can be focal, in which case it helps for localization. Ictal activity with focal manifestation may consist of simple contraversive eye movements with involvement of area 8, head and eye turning associated with arm movements, or with athetoid dystonic postures occurring if the supplementary motor area is involved. Ictal activity in the form of a speech arrest, unilateral facial twitching, followed by repetitive arm movements, occurs with involvement of the dominant hemisphere centrotemporal region. After the ictal period comes the posictal period. The posictal period starts when the electrical seizure ends. EEG usually shows low voltage activity during this period. From the point of view of seizure localization, the posictal period may be helpful if automatism continues during it, or if thought paralysis occurs. Thought paralysis is a transient, localized weakness that follows at times generalized convulsions, but more often focal convulsions. Thought paralysis are important for localizations, since the corresponding area of the brain involved in the paralysis is usually the site of seizure onset. Please go to this YouTube video. It provides a memorable recount of what a thought paralysis is. So the answer to this question is B. Next question. A 10-year-old girl that awakens from night sleep with twitching of the right corner of the mouth and then goes on to develop right arm jerking but retains awareness is likely to be having A. a metabolic seizure, B. a post-traumatic seizure, C. a lesional tumor seizure, D. an idiopathic seizure. So we know our patient's seizure type is simple partial. We know that the cerebral area involved is the centrotemporal region, and this later question refers to cause. Seizures can be classified according to cause. The list of possible causes of seizures is very extensive. A good practical approach is to initially consider, based on history and physical exam, if the seizure was provoked. This dichotomy allows to proceed with a rational management approach. When seizures are provoked, we should ask ourselves if the provoking factor is correctable. Etiology correctable seizures, as those due to hypocalcemia and hypoglycemia, should be treated, and a good response to treatment provides diagnostic confirmation as to the cause of the seizure. Etiologically not correctable seizures, on the other hand, such as a cortical cicatrix due to head trauma, requires further diagnostic corroboration. If the seizure is unprovoked, the seizure is labeled a seizure of undetermined cause. It is always recommendable when dealing with etiologically not correctable seizures to manage them as a seizure of undetermined cause until the not treatable cause is irrefutably confirmed. Just because a 35-year-old patient starts having seizure 1 month after a head trauma does not mean that the seizure is not due to a brain tumor. This figure shows the most frequent causes of seizures in relation to age. The red stripes indicate the time period when the different etiologies are more likely to be the cause of seizures. For example, at 10 years of age, the age of the patient in our last two questions, we can see that the most likely cause of seizures are stroke, tumor, infections, metabolic, birth injury, and idiopathic seizure. In real life, all these conditions pointed by the arrows should be considered and ruled out based on clinical findings in laboratory investigation. Once done, the tentative diagnosis of idiopathic seizure should be established. In this vignette, we find no history of head trauma, no clue indicating a progressive deficit to suggest a tumor, nor any alteration in mental status to suggest a metabolic disorder. So the best answer is D. Next question. A 10-year-old girl that awakens from night sleep with twitching of the right corner of the mouth, and then goes on to develop right arm jerking, but retains awareness, is likely to be having A. a petit mal seizure, B. a myoclonic epilepsy of Jan's event, C. a benign epilepsy with centrotemporal spike seizure, D. an infantile spasm. So we know the type of seizure, simple partial, the location, centrotemporal, the cause, idiopathic. The next step is to classify the seizure based on the syndromic classification. An epilepsy syndrome is defined by a group of clinically relevant features occurring together that allow us to predict the course, plan the workup, and choose the medication most likely to control the seizures. The clinically relevant features available when the patient is first seen are the type of seizure, epileptic focus localization, and age of seizure onset. I will now present a syndromic classification of seizures based on age of seizure onset. This classification establishes 5 groups: neonates from birth to 1 month, infants from 1 to 12 months, childhood from 1 to 12 years, and the 4th group lumps adolescent and adults, hence it includes patients 13 and older, and the 5th group is stable variable, implying seizures that start at any age. This age grouping represents the basis of the syndromic classification of seizures we will discuss. This classification was taken from a widely used neurology textbook, and it is given as an example of how epileptic syndromes can be arranged by typical age at onset of seizures. My purpose of showing you this classification is not for you to learn it, but just to glance over it so you are aware of it. You will find it useful next year when you start taking care of patients, but for now, just know that it exists and how to use it. I will show you how to use it in the next few frames. As you can see, in the neonatal period, there is a set of syndromes, another set of syndromes in infancy, another in children, another for adolescents and adults, and the last group is the one constituted by those epileptic syndrome of variable age of onset. Being that our patient is 10 years of age, we need to consider syndromes with seizures of childhood onset and those that can start at any age. I have compiled a list in this frame of all the syndromes under those 2 headings. You do not need to read them. Remember, I am only interested in showing you the mechanics of how to do this. So we will further narrow the possibility in a few minutes by a process of elimination. Being that the type of seizure is simple partial, we only need to consider those seizures with focal onset. In this new frame, I have changed the font color to magenta for syndrome with partial onset. Being that the seizure focuses centrotemporal, we can narrow the possibilities to those syndrome with preferential involvement of the centrotemporal area or syndrome with seizures foci that have no regional predilection. This process leaves us with 2 possibilities. So the answer to this question, given the fact that familial focal epilepsy with variable foci is not a choice, the answer is C. In real life scenario, we would also consider this patient as having benign epilepsy with centrotemporal spike for 2 reasons. 1, benign epilepsy with centrotemporal spike is more common than familial focal epilepsy with variable foci. And 2, although benign epilepsy with central temporal spike can be found in several members of the same family, the family tendency of familial focal epilepsy with variable foci is stronger. Next question. Which of the following EEG patterns is most likely to confirm that the patient described in the prior questions has benign epilepsy with centrotemporal spikes? A. 3 per second spike and wave. B. Photic-induced 6 per second spike and wave. C. Unilateral centrotemporal spikes. D. Bilateral centrotemporal spikes. Absent seizures are associated with 3 per second spike and waves with a generalized distribution. The events can be triggered by hyperventilation. Myoclonic epilepsy of Jan's is characterized by morning myoclonus. They usually occur at the time the patient is cleaning their teeth, so they drop the toothbrush and the toothpaste as depicted in this frame. Myoclonic epilepsy of Jan is also associated with a spike and wave, but the frequency of the spikes and waves complex is more than 3 per second, usually 6 per second. When the myoclonus is brief, there is no loss of consciousness, but if prolonged, consciousness is altered. Episodes are triggered by phonic stimulation in patients with myoclonic epilepsy of chance. At times, when the episodes are prolonged, clear episodes of absence are present, or generalized tonic-clonic seizures may occur. Benign epilepsy with centrotemporal spikes cannot be, by definition, diagnosed without EEG confirmation. Yet at times, when clinical suspicion is high and other causes are excluded, the diagnosis is tentatively made and medication is started on clinical grounds. Yet, most often, centrotemporal spikes can be detected, especially if the EEG is recorded during sleep. Sleep, in these cases, is considered a provoking EEG maneuver. This EEG epoch shows left centrotemporal spikes. These spikes are interictal because they occur when the patient is not having clinical manifestation. The presence of unilateral spikes supports the diagnosis of benign epilepsy with centrotemporal spikes, yet it does not exclude the possibility of a tumor in the same area being the cause of the seizures, since tumors in the centroparietal region can produce simple partial seizures characterized by speech arrest, hemifacial twitching, arm jerking, and unilateral centrotemporal spikes. A more reassuring EEG pattern is the one presented in this frame. You see spikes on the right. Notice the number of spikes are even, and also on the left. This pattern is almost exclusively present in patients with benign epilepsy with centrotemporal spikes. This new epoch is characteristic of an ictal seizure occurring in a patient with benign epilepsy with centrotemporal spikes. Notice the onset of the electrical seizure is shortly followed by hemifacial convulsions. So the answer to this question is D. Next question. Pyridoxine vitamin B6 dependency is considered a neurotransmitter synthesis problem, B, excitatory neurotransmitter receptor problem, C, inhibitory neurotransmitter receptor problem, D, dendrite malformation problem. Why seizure happens? A seizure results from a massive simultaneous depolarization of cortical neurons. So then the question is, why cortical neurons massively depolarize? In this frame, I will introduce a table that draws parallelism among brain elements involved in the production of seizures, conditions produced by their involvement, and pathological mechanism producing the seizure. Probably one of the most common causes of recurrent seizure is abnormal neuronal network. This occurred in patients with cerebral dysgenesis, post-traumatic scars, and mesial temporal sclerosis. This is an MRI of a patient with left hippocampal sclerosis, a term clinically interchangeable with mesial temporal sclerosis. Notice how small the left hippocampus is in relation to the right hippocampus. In this frame, I have included the histological appearance of a normal hippocampus and the appropriate legend. Notice the nice configuration of the dentate gyrus and the neuronal density in the different sections of the cornu anonis 1 through 4. I have now introduced an abnormal hippocampus. Notice the difference. The dentate gyrus is hardly recognizable and the number of neurons in C1 to C4 are greatly depleted. Going back to the table, you can see that the likely pathological mechanism in this condition is altered neuronal circuitry and the formation of aberrant excitatory connection. Involvement of neuronal structures is present in conditions such as Down syndrome and other mental retardation syndromes. The likely pathology in these cases is abnormal dendritic spine and altered current flow in neurons. This is a drawing done by Miguel Marín Padilla from a Golgi preparation. It depicts a segment of an apical dendrite of a layer 5 pyramidal neuron of a neurologically normal neonate during life. This is the dendrite. These are the spines. The spines are the small protruding membranous organelles found in dendrites where the dendritic synaptic connections take place. Compare them with the dendrites and spines of a neuron of a patient with Patau syndrome. The spines in Patau syndrome are sparse and longer than expected for a neonate. Patau syndrome is mentioned in the First Aid USM Elite Step 1 book. You may want to take a screenshot and review it later or go to the book and review it. This is a drawing from a Golgi preparation depicting a segment of an apical dendrite of layer 5 pyramidal neuron in an 8-month-old with normal neurological exam during life. This drawing I just introduced is from an 18-month-old child with Down syndrome. The child with Down syndrome has shorter and thinner spines. We'll now address neurotransmitter synthesis involvement. Neurotransmitter synthesis involvement occurs in pyridoxine dependency seizures. In patients with this condition, the cause for seizure is believed to be decreased GABA synthesis. This condition, that is pyridoxine dependent seizures, result from a problem in the lysine pathway. This pathway converts L-lysine to alpha-aminoadipic acid. One of the enzymes in this process is alpha-aminoadipic semialdehyde dehydrogenase, also called antiquintin. This enzyme is produced by the instruction of the ALDH7A1 gene. So when this gene is affected, antiquintin is not produced, and so a block will occur, leading to an increase in piperidine carboxylase, as you can see in this frame. Piperidine carboxylase binds with pyridoxine, forming a compound resistant to the action of pyridoxamine oxidase, the enzyme that transforms inactive pyridoxine to active pyridoxal. Hence, the limited availability of pyridoxal alters many cellular functions, including the conversion of glutamate to GABA, since pyridoxal is a cofactor necessary for glutamate decarboxylase, the enzyme that converts glutamate to GABA. Seizures can also occur due to inhibitory neurotransmitter receptor involvement, as it does in patients with Angelman syndrome and in patients with juvenile myoclonic epilepsy of Janus. In these conditions, abnormal GABA receptors unit appears to be the pathological mechanism producing them. Excitatory neurotransmitter receptor pathology occurs in non-ketotic hyperglycinemia, resulting from overstimulation of the NMDA receptors. Glycine is, as you know, a cofactor in the stimulation of these receptors. Involvement of synapse during development occurs in neonatal seizures because of the alleged depolarizing action of GABA early in the development due to the higher concentration of extracellular chloride in this age group. Involvement of ionic channels, among which some authors include the previously mentioned neurotransmitter receptor problems, occur in benign familial neonatal convulsions and Dravet syndrome. Dravet syndrome is a type of epileptic syndrome that occurs during infancy. Channelopathies can affect potassium and sodium channels. The last element I would like to cite are astrocytes. Astrocyte dysfunction leads to glia failure convulsion, which may contribute to mesial temporal lobe epilepsy. The likely pathological mechanism is failure of removal from the perineural extracellular space potassium and glutamate. So the answer to this question is A. Next question. Convulsive generalized seizures is considered established status epilepticus if A. Lasts for 5 minutes, B. Lasts for 30 minutes, C. Lasts longer than 5 minutes and does not stop after benzodiazepine, D. Lasts longer than 3 minutes and does not stop after benzodiazepine. Status epilepticus has had many definitions through time. Currently, we consider convulsive status epilepticus when a generalized convulsive episode lasts longer than 5 minutes. Ongoing generalized convulsion for 30 minutes are likely to produce long-term brain damage. Focal complex partial seizures reach the level of status epilepticus if lasts longer than 10 minutes. Ongoing focal complex partial seizures longer than 60 minutes will produce cerebral brain damage. Absent status epilepticus is diagnosed if the episode lasts longer than 10 minutes. It is not known how long it takes for damage to occur in this condition. Established status epilepticus implies that the episode lasts longer than 5 minutes and the seizure has not stopped after given the first appropriate dose of benzodiazepine. Refractory status epilepticus, again referring to convulsive status epilepticus, is defined as an episode lasting longer than 5 minutes and the seizure not stopping after giving the first appropriate dose of benzodiazepine and a second-line anti-epileptic drug. The term epilepsia partialis continua refers to unrelenting simple focal seizures manifested by convulsions with retained awareness occurring for over 1 hour. This type of seizure may last for a very long time. So the answer to this question is C. Next question. In which of the following conditions is seizure less likely than deafness? A. Sturge-Weber syndrome, B. Tuberous sclerosis, C. Neurofibromatosis type 1, D. Neurofibromatosis type 2. The answer to this question lists 4 neurocutaneous syndrome. These syndromes are frequently found in exams and in clinical practice. The first one is Sturge-Weber syndrome. Sturge-Weber syndrome is a congenital non-hereditary anomaly of neural crest derivates. The neural crest derivates are cells that develop from the interface of the neural groove and the neural folds in early development. These cells become unattached to the neural tube, migrate, and form many different types of tissues. In patients with Sturge-Weber syndrome, the anomaly of the neural crest derivate is restricted to some regions of the facial area. The affected gene is GNAQ. This gene is on chromosome 9. Sturge-Weber syndrome is characterized by the presence of port 1 stain in the distribution of V1 and V2. Skull films in adults may show calcifications in the form of railroad tracks. The brain also shows leptomeningeal angioma. Ocular findings are prominent in Sturge-Weber syndrome. They include episcleral hemangioma, glaucoma, and ophthalmos, as you can see in this MRI. The second syndrome is tuberous sclerosis. Tuberous sclerosis is an autosomal dominant condition of variable expression. Tuberous sclerosis is due to mutation in two tumor suppressor genes. The tuberous sclerosis complex 1 gene on chromosome 9, which encodes a protein called hamartine, and tuberous sclerosis complex 2 gene on chromosome 16, which encodes a protein called tuberin. The cutaneous manifestations of tuberous sclerosis are very florid. They include facial, formerly wrongly called adenoma sebaceum, chagrin patches. Chagrin patches are patches of raised and rough to the touch on tan skin. Ash leaf spots are unraised spots. They are easily seen in patients with dark skin, but require using a special violet light from a lamp called Wood's lamp to be visualized in patients with light skin, as you can see in this frame, indicated by the arrow. Fungal fibromas are also frequent in this condition. Tuberous sclerosis also affects the heart. In the heart we find rhabdomyomas. The kidney. In the kidney we find angiomyolipomas. In the lungs we find lymphangioliomyomatosis. And the retina. In the retina we encounter tumors. Patients with tuberous sclerosis often have seizures and mental retardation due to different pathologies that can affect the brain. We often find calcifications by the orifice of Monroe, as indicated by the arrow, subependymal giant cell astrocytomas, cortical tumors, as you can see here, and here. Another brain pathology often found in these patients is cortical dysplasia. The third condition mentioned in this question is neurofibromatosis type 1. Neurofibromatosis type 1 is an autosomal dominant condition with 100% penetrance, meaning if you have the gene, you have the disease. It is due to a mutation in the NF1 tumor suppressor gene on chromosome 17, which encodes neurofibromin. The most noticeable manifestation in patients with neurofibromatosis type 1 is the presence of multiple caveolate spots. They are often present under the armpit. Other cutaneous manifestations are neurofibromas. They often occur in the hand, neck, and eyelid. When present in the eyelid, they may be associated with optic glioma. Optic gliomas may also be present in patients without cutaneous neurofibromas. Other ocular manifestations are leech nodules. They look quite different in patients with brown and blue eyes. They look whitish in patients with brown eyes and coffee colored in patients with blue eyes. Leech nodules are neurofibromas of the nerve in the iris. Neurofibromatosis type 1 is at times associated with pheochromocytoma and sphenoidal dysplasia. Cerebral hamartomas are also found in these patients. The fourth condition is neurofibromatosis type 2. Neurofibromatosis type 2 is an autosomal dominant condition due to mutation in the NF2 tumor suppressor gene on chromosome 22 that produces a protein called Merlin. Patients with neurofibromatosis type 2 may present with unilateral tinnitus and sensory neural hearing loss due to unilateral vestibular schwannomas. Weber tests will show decreased hearing on the side of the lesion. Rhine tests will show that once a sound conducted by bone is no longer heard, the sound conducted by air can still be heard. Hence, air conduction is more than bone conduction. The non-affected ear will show, although much louder and longer lasting, the same relation between bone and air sound conduction. Patients with unilateral vestibular schwannoma may also present with peripheral facial nerve palsy. This is because of the proximity of the 7th and 8th cranial nerve and the location of the lesion at the cerebropontine angle. Thus, the growth of the tumor will compress the facial nerve, and further growth will compress the left lobe of the cerebellum, producing ipsilateral ataxia. Notice that in this case, the unilateral vestibular schwannoma is on the left side. Some patients with neurofibromatosis type 2 present with bilateral tinnitus and sensorineural hearing loss. In these cases, if both ears are equally involved, Weber test shows bilateral decreased hearing with no ear preference. During the Rhine test, the sound transmitted by bone conduction on the right ear and the left ear lasts less time than when the sound is transmitted by air conduction. This indicates that air conduction is better than bone conduction. The cause of bilateral tinnitus and sensory neural hearing loss in patients with neurofibromatosis type 2 is bilateral vestibular schwannomas. Meningiomas also occur in this condition, as you can see in this MRI. Posterior subcapsular cataracts often occur in patients with neurofibromatosis type 2. So the answer to this question is D. Thank you very much for your attention.